this week on the Backtable podcast.
That's why this condition is so fun to manage. Once you identify it, which is the harder part, you should be seeing 90-95% success if you've addressed the teeth appropriately and the sinuses adequately. I think it's important, though, that people don't think it's just 100% success, because I know some people presume that. There's even some series, showing 100% success, but nothing can really be 100%, in my opinion. And I've seen, so we just put this out, and we did actually achieve 98% long-term resolution endoscopically and symptomatically, which was awesome.
Hi, everybody. Welcome to the Backtable ENT podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. My name's Ashley Agan. I'm a general ENT, and I'm pumped to be across the mic from my dear friend Gopi Shah today. I've been out for a while because I got labyrinthitis.
Do you want to tell everybody what happened?
I mean, like legit vertigo, sensorineural hearing loss, out for the count, and I had to do the whole thing. Antibiotics, steroids, high T steroid injections ×3, vestibular rehab, all the things. But I'm doing so much better, and I'm so excited to be podcasting again. Excited to be here with my dear friend. How have you been, Gopi?
I'm good. I'm just happy to have you back and see you. And congratulations on completing and graduating vestibular PT. That's huge. You worked hard.
Thank you. All right, let's intro the show. We have a great guest. Dr. John Craig is here today to talk to us about Odontogenic Sinusitis, or as we'll call it, ODS. Dr. John Craig is Chief of Rhinology and Co-Director of the Skull-Base Center at Henry Ford Health in Detroit, Michigan. He's here today to talk to us about odontogenic sinusitis. He is the lead author of the International Multidisciplinary Consensus Statement on the Diagnosis of ODS, published in 2021 in IFAR, and a state-of-the-art review on ODS in the World Journal of Otorhinolaryngology, HNS, in March of 2022. Well, welcome to the show, Dr. Craig. How are you?
Excellent. Thanks so much for having me. Excited for this.
Thanks for coming on. Can you first just tell us a little bit about yourself and your practice?
Yeah, I am currently, of course, in Detroit, but I hail from Northern California and Eureka, California. I don't know anyone else in Michigan from there and haven't gone back there since. But basically, I spent most of my time on the East Coast. I went to Cornell for undergrad, went over to Chicago at Rosalind Franklin for med school, back over to Syracuse, SUNY Upstate for ENT, and then did my rhinology fellowship at the University of Pennsylvania. And then ever since then, I graduated in 2015, started at Henry Ford, and I've been here ever since. And it's been great. I think from the purpose of why we're talking today, I've taken a research interest in odontogenic sinusitis, amongst other topics too, but this one stuck out to me as one that really needed some extra love, if you will, since the literature really wasn't guiding us a whole lot on the diagnosis and treatment of the condition. And I was seeing it so frequently right out of training. So I felt like there was a gap there and collected some data prospectively, and now here we are. And my only other thing to, report about myself is my family, which is extremely important to me. And I wanted to give a quick shout out to my two children, Liam and Nora, both whom seemed somewhat interested in the fact that I'd be on something like radio. So, hey there, guys. And then, of course, shout out to my wife, Devin, who makes all this sort of academic ridiculousness in my life possible. So that's me.
Awesome.
How old are Nora and Liam?
Nora's 7, Liam's 9.
Okay, so they're the age where maybe they can, listen at least listen to the shout out.
For sure.
So starting out, let's just kind of set the stage with terminology overview. When you're speaking of odontogenic sinusitis, kind of comparing it to other forms of chronic rhinosinusitis or acute sinusitis, and how do you think about that?
Yeah, it's so critical, but until recently, we didn't have just like a simple definition. So what we've tried to be consistent with in recent studies, both consensus statements, there's a treatment consensus and a diagnostic consensus out there. Here's the definition. Bacterial maxillary sinusitis, with or without extension to other paranasal sinuses, secondary either to adjacent infectious dental pathology or following complications from dental procedures. So it's a mouthful, but it covers all the different etiologies that cause dental-related sinusitis. And so we're trying to be all-inclusive and make sure we're not forgetting about all the different types. Now, I believe you said how to compare it or contrast it to rhinosinusitis. It is distinct. It is not chronic rhinosinusitis. And I think this is a problem in older literature. It almost talks about it like it's a subtype of rhinosinusitis. It's just completely different. It's a secondary sinusitis caused by, like we said, dental pathology or dental complications from procedures. And so we really just have to keep distinguishing it. What are some clinical differences? Well, for one, this is a condition that's almost always unilateral. Very simple distinguishing point. Most rhinosinusitis is bilateral. So 90 to 95% of ODS is going to be unilateral. We mentioned that it's distinct from the standpoint of it being from oral or dental bacteria. Another distinct point is that there's no deficiency in mucociliary function. It's been shown in multiple histopathologic studies. The mucociliary function is presumably intact as opposed to some forms of rhinosinusitis where it might be distorted. We know that there's different microbiology behind this. We mentioned dental and oral bacteria. That's been shown in multiple studies, including one from us, just that oral anaerobes and oral alpha hemolytic strep species, for instance, like Strep intermedius, Strep constellatus, are definitely more common in ODS. There's been more that's come out over the last few years. For instance, we just published a recent study on endotyping with regard to ODS, which is a hot topic in rhinosinusitis, but ODS sort of just got grouped into other forms of rhinosinusitis without being separated out. To simplify that point, it's just that we showed a Th1 skewed endotype, which would, I think, be expected by a lot of researchers. But I think it's important to recognize that so that in future endotype studies, we can separate that out. All right. And then lastly, I would just say, symptomatically speaking, we'll probably hit on this multiple times because of how important it is. Patients will often complain of a foul smell in their nose. This is also pretty unique, not specific per se, but most people with rhinosinusitis don't have a foul smell, whereas ODS patients often do. Hopefully that's not too much.
Yeah, no, that's great. Do these patients present more an indolent presentation, or are they usually coming in acute, a few day history of this foul smell, and they come in acute to you?
By far, the majority, overwhelming majority, I should say, is chronic. And that's not just my practice, which is definitely true in my practice, but it's in almost all the literature. These patients present with a median of 6 months of symptoms when they present. And just for some reason, it gets misdiagnosed or missed by all the different providers that have seen them previously. But yeah, definitely chronic, most common. And then there are the occasional patients who will present right after a dental procedure, which is interesting, within the first week even, and they'll have full-blown odontogenic sinusitis, but that's less common.
Yeah. You'd mentioned Strep intermedius. I think of like complications of acute sinusitis with the eye or intracranial. How common does ODS have a complication to the eye or the orbit?
I love it. I love the question because we happen to have published something on this. I don't know if you read this, but so absolutely ODS can cause orbital, intracranial, osseous, as well as systemic extrasinus infectious complications. I was finding it interesting in my practice that most times I was taking patients to the OR emergently or urgently for these complications. They were unilateral cases. And lo and behold, I was seeing dental sources. So I approached University of Pennsylvania, my former mentors, and we put together a retrospective study looking at all operative extrasinus complications over 15 years. And what we found was really interesting. So amongst patients with unilateral sinusitis, if we excluded fungal etiologies, 60% of them, so 2/3, had odontogenic sources. So amongst patients who get these complications, it is highly prevalent. I think on the whole, most ODS does not cause extrasinus complications, but it's well documented in the literature. We actually put out a systematic review on this topic, and there's, I think, 110 published cases of extrasinus complications from odontogenic sinusitis. I won't get into the weeds too much, but there's also the potential for dental sources alone to cause all these extra sinus complications regardless of the sinusitis. But nonetheless, it's uncommon on the whole. But when you see these cases, unilateral presentations, look down at the teeth because you'll be surprised how often there's a dental source.
Yeah, just kind of taking us from the beginning when patients are coming in, can you talk to us about the stereotypical patient that comes in that you're seeing that ultimately has ODS? Obviously, not everybody's the same, but you've mentioned the foul smell. Is there anything else in the history that kind of tips you off to thinking that it could be ODS?
Yeah, I think first off, people just have to flip a switch in their head that this is more common than most people think. And once you start thinking about it or looking for it, you find it more. I know that sounds obvious, but the problem is that all of these patients will have the cardinal sinusitis symptoms to some variable frequency. So they're going to have nasal obstruction. They're going to have anterior drainage, posterior drainage, facial pressure, sometimes smell loss, and different permutations of all those symptoms. So the symptomatic history by itself doesn't say, oh, it's definitely dental. If you happen to remember to ask about foul smell, which is not one of the cardinal symptoms in all national and international guidelines, then you might pick up on that. The other thing is unilateral. Okay, so I've noticed reading a lot of doctor's notes, they're all or none symptoms. So instead, you need to know whether that nasal obstruction's one-sided or both sides. Is the colored drainage one side or both sides? And it's just been interesting to me noticing that not everyone asks that simple question. So try to focus in on what's unilateral or bilateral, and then that foul smell will be a little extra in terms of suspicion.
How common is it for a patient to have associated tooth pain, jaw pain, gum pain?
Intuitively, you'd like to hear that was a predictive symptom. Unfortunately, the studies that have included dental pain in symptomatic history in their data collection, it's been about 20 to 40% of these patients have dental pain. Now, I would argue, unfortunately, I don't think most people ask, for one. And then the other problem is these teeth are usually necrotic or absent. They may have had their tooth pulled. So for multiple reasons, either people aren't asking or they're just not painful etiologies. That symptom's not helpful. I actually always do ask because I collect it as a data point, but unfortunately, it's not hugely helpful.
When you're asking, are you asking broadly, do you have dental issues, pain in your teeth? Have you had a recent extraction? Do you have dental implants? How specific are you?
So I try to be pretty methodical. So I'll, for one, ask about upper dental pain. Sometimes people just write dental pain and it could have been their lower teeth. That's not going to cause odontogenic sinusitis. So I try to get then into show me which teeth hurt. And then prior dental procedures are a great one, but interestingly hasn't been studied as a predictive variable. So have they had a prior filling, for instance? A lot of people have had fillings. Those fillings break down over time. It would be very interesting to know what percentage of ODS patients had a prior filling. That's not published. Root canals definitely put a patient at risk, not necessarily because of the procedure, but because they probably had endodontic pathology that caused a sinusitis. And so knowing that definitely increases my suspicion. And then, yes, extraction, dental implants, bridges. I didn't know much about basically any of the procedures I just said, but bridges actually put people at pretty significant risk for dental disease because they drill down a tooth. And it's not an insignificant percentage of people who get endodontic pathology from that down the road. So yes, I try to delve into dental history, but frankly, I don't think we're trained in ENT residency what questions to even ask. So it feels like almost too much to ask in a very busy clinic, if that makes sense.
Yeah. A question for you for the prior filling history or root canal. Is there a certain time frame? Because fillings can break down 10, 20 years later, or, is the filling within 6 months? Does that tip you off at all? Because I would say 100% of people have had fillings.
That's exactly what I think it needs to be studied. It just hasn't been studied, so I wouldn't be able to tell you, but it would probably be a long-term thing. Maybe 10, 20 years ago, they had a filling, but that's totally speculation. I know root canals are another one where, depending on what source you read, it might say that they fail 10 years down the road or further. And so that can be a source for bacteria from the mouth to get through into the apex of the tooth.
And most of the time, the patients are coming to you kind of without that suspicion. So it's not like the dentist is sending them to you thinking like, oh, they have odontogenic sinusitis and there's some dental disease. It's usually you finding it and then sending them to a dentist. Yes?
Yeah. No, you're totally right. I think a lot of people think, this is just a funny side point, they think that because I study this, that I must be getting a lot of referrals for it. But it's not the case. We actually just published a paper showing that 85% of ODS cases that I've seen over the years have all been identified by me. So we can talk about this probably with treatment, but I've made some networks with different dental specialists around here. And I've still found it interesting that they don't send me very many patients. It's usually me sending my patients to them. So it definitely is it's kind of the onus of the ENT surgeon to recognize this.
Are there any other risk factors? Could a broken tooth or a loose tooth? I mean, maybe there wasn't a dental procedure that kind of preceded this? Are there any other groups that you have noticed that, hey, these people are at higher risk or anything like that?
I mean, I think those types of dental procedures we talked about are higher risk, but it hasn't been studied specifically. We don't know if certain dental treatments are specifically putting patients at more risk. I think that because we know endodontic disease, condition called apical periodontitis, where you get infection of the pulp space, spreads out the apex of the tooth, that's the most commonly reported type of odontogenic sinusitis. So I think it's safe to presume that if you hear they've had a prior root canal, that means they had endodontic disease. That would make sense. A prior extraction also, you would think, has to put a patient at risk, but it just hasn't been studied. So I wouldn't want to say anything definitive, but I have not seen any immunocompromised patients with ODS. So we can't blame their immune system on this. And no, other than that, nothing sticks out to me.
Or like trauma or anything like that?
Like facial trauma or dental trauma?
Yeah, both.
Yeah, I mean, I've seen those cases after Lefort fractures and a nasty sinusitis that's growing oral bacteria, but that's sort of a different ballgame altogether. We're not even really calling that odontogenic sinusitis. But yeah, if you have a fracture through a tooth socket, it's got to put you at risk. Nothing quantitative out there.
What about sinus lifts? You have these patients that get these procedures so that they can be a candidate for implants called a sinus lift. Like, do you see that they are at increased risk?
Well, so this would require a good collaboration with dental implant specialists to truly know what this risk is. Because if you read their literature, it says 1%. Patients who get a sinus lift with bone grafts, augmentation to the sinus floor for that eventual implant, 1% risk of sinusitis. But here's the thing. Every study I've read on that doesn't collaborate with ENT. So they're not scoping patients. We don't know if they've developed infectious purulent sinusitis after said procedures. I will say, just all I can speak to is my practice of all the ODS cases I treat. They are the minority, but from a phenotypic standpoint, they're just the same as all the others. They're nasty, purulent infections. And what's interesting is sometimes the bone graft needs to be removed, but then other times it's mucosalized in the sinus. There's no fistula in the mouth, and we just address the sinusitis and don't have to take out that bone graft. So this just gets to the point of really needing that collaboration between dental providers and ENT to really know if that bone graft did cause a sinusitis. Does that make sense?
Mm-hmm. Yeah. So moving on to your exam, I assume you have typical rhinology exam where you're looking in the nose and you do endoscopy. When it comes to your exam, your oral exam, what are you thinking when you're looking at teeth? And I know when I look in the mouth, I'm like, oh, that tooth looks kind of funny, or maybe. I can't say that I feel very confident about what I see.
Are you tapping on any of the teeth with a tongue blade? Like,
I know.
Checking for loose,
these
feeling
are
the
all
gums?
really important questions, and we don't have answers for them yet. And so I'm going to go to my anecdotal oral exam process, but I can tell you, does not predict ODS in either direction. So if I see a diseased tooth, frankly necrotic, horrible looking tooth, totally clear sinuses. And then the flip side's true, really healthy looking dentition, we get the scan and oh my gosh, it's a huge periapical abscess, bone erosion into the sinus. So unfortunately for me so far, I just haven't studied it methodically, but I don't think there's a clear correlation between the oral exam and the sinuses. But what do I actually look for? I do look for prior dental work because it just makes sense to me that if they've had something done that affects the possible spread into the pulp chamber, then that's going to increase the risk for sinusitis down the road. If they've had a prior extraction, I'm looking at that. I should mention that the molars are the main culprits here. So it's actually going to be a cool study that we haven't put out yet, but looking at the relationship of the tooth sockets to the sinus, the first and second molars are generally closest to the sinus floor. They're the highest risk teeth, basically regardless of dental pathology. So either endodontic pathology with intact teeth or prior extractions causing a fistula. Those are your biggest bang for your buck. So I tend to look at the posterior dentition. That said, we've all seen a first or second premolar also cause disease, and in a very rare situation, a canine. But I'm looking at all those teeth mainly just to try to correlate to what I'm going to see on my endoscopy. I mentioned prior dental work. Overt dental disease obviously is suspicious. Necrotic tooth that's fractured, black looking. And then don't forget to look at the gum line. So right above the tooth roots, if there's a raging dental process, there will be fullness there. You also might see pus draining through the tooth socket. And so I think those are the main things I'm looking for. And then, like you mentioned, the scope. The scope is huge.
What do you see on it? Tell us.
Yeah. So once again, unilateral comes to mind. So we've shown, and it's not just our studies, other studies have shown this too, 80 to 90% of true ODS, infectious sinusitis, is going to show pus. So you look for pus coming from the middle meatus, and then you're comparing to the other side. So if you see unilateral pus, it's just such a simple thing to identify for us. But we've got this really cool study that showed in a prospective cohort fashion that finding in patients with unilateral maxillary sinus opacification on a CT scan, 17 times more likely to have an odontogenic source. So it just gets back to this unilateral point. If you see unilateral pus on scope, be suspicious for ODS. If you see unilateral opacification on a CT scan, be suspicious for ODS. And then the only other point I'd say about scope is that polyps are actually not that uncommon for ODS. It's the minority, but about 20 to 30% in 2 studies from us, and it's been shown in other studies too, have severe, I think most physicians would call them polyps, whether it's polypoid edema or legit multilobulated polyps, can be seen in odontogenic sinusitis. And I know that there's a study in the past that suggested ODS was a non-polypoid condition. I think that is not a good way to think about it. These cases can have severe edema and sometimes, frankly, look like a tumor, by the way.
Like IP or something? Like
exactly.
Potentially confused for.
Yeah. And I just presented this at a recent ARS meeting, but I mistakenly early on in my practice took a person to the OR for almost certainly an IP. It looked like papillomatus. There was pus, but did a medial maxillectomy to remove the tumor and came back negative for IP. And I know there are others out there that have had this happen to them too. And so my point there is just that pus unilaterally should tip you off to potential ODS. And then if you see polyps, don't presume that it's not ODS.
And when you're looking in the mouth, again, like I'm thinking about a particular patient one time that had a fistula, but it was so tiny. And I remember trying to find it in the OR and like having to like have like a tiny little probe and kind of just gently probing around in there to finally even find it because I couldn't see it. Do you poke around at all in the clinic or how?
Yeah.
How much in the mouth?
How much time do you spend?
Yeah.
Well, that's the thing. I mean, I don't know how many people do that. But I agree. That is one way. So in our consensus, we had a bunch of dental providers on that consensus. And consensus was that there are 2 ways to assess for a fistula. One is what you said. You could probe for it. Simpler method that's pretty reliable is have patients plug both nostrils and with an open mouth, blow. And I've definitely seen the bubble effect coming through a tiny pinpoint fistula. So that's one simple way. If you have a little probe, though, that is also a great way. I mean, I've seen some, just like you said, really creepy ones where it's not even a pinpoint, but I sent him to a dental provider. I've got this great video where he takes this really fine probe and he's scraping along the gingiva and then slides into this hole and goes straight through the sinus. And you definitely couldn't see it on exam. So yes, when you see somebody with a prior extraction, I'm not saying you don't necessarily have to repair these tiny pinpoint non-visible openings, but they do exist.
Yeah. So take-home points for while you're kind of seeing these patients in clinic are foul smell, unilateral, ask about unilateral. There's going to be unilateral exam findings like pus and could be polyps and kind of an angry looking endoscopy. And then I suppose, I bet a lot of patients come to you with a CT scan already, but I mean, if not, then that's the next step.
Yes.
Do you, can I step back for 1 second? Do you ever culture the pus? Do you ever do that?
I do. So I used to do it on everyone. The thing I was finding tricky in some of these, you got this little stream of pus, despite it being floridly infected. And just because of endoscopic access issues or the amount of pus you can get, sometimes the culture results in the office aren't particularly helpful. But I usually try to, because here's the scenario that's tricky. What if you don't have that CT scan and you've got somebody with unilateral pus? I know a lot of people out there will treat that as maybe even a recurrent or chronic infectious sinusitis and keep treating, because some people will lean on, you got to try multiple courses before you do anything more. And then they won't get a CT scan because some people would say you don't get the CT scan unless you're planning surgery. So I guess my point is, if you get that culture, if you can, adequate access, adequate pus, get it, because that, if it shows you oral bacteria, that'll tip you off and say, okay, we actually should get the CT scan. Does that make sense?
Yeah. So when you're getting a CT scan, do you guys have a scanner in the office, or do you have to send them out for their CT?
We have them in the hospital. So each clinic site that I work at, Henry Ford, they have a radiology department at each spot. So not in the office, but it's pretty easy to get the scans expedited.
Yeah, but they're not like sitting. It's not like, oh, go get your CT and then come back into the exam room and then we'll talk about it. You know, there's like,
no,
they go across the way and get it.
Yeah, and then I just call them.
Yeah. And then, I mean, I would assume that CT's your big workhorse. Is there any reason to get any other imaging? Do you ever think about MRI or?
Oh, right.
Or contrasted or panorex?
Yes, the dental imaging effect. Okay, so first, from the sinus standpoint, I just get a non-contrasted sinus CT. As far as contrast or any kind of other modality like MRI, that's going to be more in the setting of extra sinus spread, or maybe you're not sure if this is a tumor and there's bone erosion with possible extension of the orbit, face, brain, something like that. That's going to be, I probably wouldn't be getting MRIs on most of these people.
Before we get to panorex,
Yep.
What are your typical CT findings? Is it a hyperexpanded max that's like blown out, or the onsonet's going to be sucked in laterally to the lamina? Like what is your typical findings for this on the unilateral and the max?
Yeah. Subtotal to total opacification of the maxillary sinus is going to be most common. This actually is a nice segue into the mucosal thickening dilemma. So one point I want to hit on a couple times during this today is that mucosal thickening adjacent to dental pathology or dental work is not what we're talking about with odontogenic sinusitis. Unfortunately, the literature kind of lumps it in there sometimes. That's a problem. And so that's just reactive mucosal inflammation to underlying dental pathology, responds very well to dental treatment. But a true infectious ODS, like we're focusing on for the most part, you won't see an atelectatic sinus. You'll definitely see bulging out of the uncinate process. There's actually a nice study by Alberto Sabin out of Milan, actually. He published a study showing that the angulation of the uncinate bulges out more in ODS. So you'll see that in the maxillary. And then in my practice, you usually see some extension to the ethmoids, plus or minus frontal. I think this is an important point. You usually see relative sparing of the posterior ethmoid and sphenoid sinuses. So infection drains into the middle meatus, presumably then can access the anterior ethmoid. Some patients, it's all like the 5% range for my practice, get into the posterior ethmoid and sphenoid. So it's possible, it's just a lot less common.
Any bony changes? Like, does anything look more osteotic or?
Yeah, so I would say the majority, I actually have this data, I just haven't looked at it in depth, but majority have thickened hyperostotic walls. But the weird thing is, you also, not an inconsequential number of people have bone erosion, like creepy spots, like the pterygopalatine fossa. They'll read it as possible invasive fungal sinusitis or tumor extension into the pterygopalatine or infratemporal fossa. We see erosion into the orbit, skull base, and not necessarily presenting with those extra infectious complications. So it's another reason why that IP that I mentioned had bone erosion. And I'm like, all right, this has got to be a tumor. So the imaging findings can be variable, but I think the biggest things are maxillary. It's got to have maxillary opacification. And then more, like you said, alluded to, the bulging of the uncinate, ethmoid or frontal disease, much less likely sphenoid and posterior ethmoid.
Yeah. And is a panorex helpful?
On the whole, not so much. So if you have networks or dental specialists you can work with, I would defer to them for the most part, but it's well established in their literature that cone beam CT scan outperforms panorex or periapical x-rays. So the x-ray modalities like panorex and periapicals, they're just not great resolution. The benefits is they do show the whole height of the tooth, including the apex. So that is better than nothing. But due to things like facial and like zygomatic arch superimposition and the haziness of the maxillary sinus mucosa and edema, it's just sort of a messier study. But not all dental providers have a cone beam CT scanner. So you got to find, mostly those are going to be in dental specialist offices, endodontists, periodontists, oral surgeons. And so if you can get them to get that, it's better. And I used to wonder, well, a sinus CT scan shows the teeth actually pretty nicely. But they've shown me some cases where there was barely any finding on the sinus CT scan. And then they get the zoomed in higher resolution cone beam. And sure enough, there's a little more bone erosion around the tooth socket that I couldn't see. So I think there is some benefit there.
How often do you not have a positive dental finding on a CT scan with ODS that you're concerned for?
It's important. The majority, fortunately, do show what I'd call overt dental pathology on the CT. So nice raised periapical lesion with bone erosion, maybe other bone erosion around the tooth socket, absent tooth, dental implant, all the really kind of obvious findings. Unfortunately, there's not great studies yet. There's 2 studies that I'm aware of. One was from Rod Tatarin. He published a series showing that almost 30% of ODS due to endodontic disease had no dental findings on the sinus CT. And then we showed similarly, almost 30% of my patients with endodontic disease have subtle to absent dental pathology on a sinus CT scan when there's endodontic disease causing odontogenic sinusitis. Okay. Well, the problem is that one of the studies was retrospective, and none of the studies followed all patients with unilateral maxillary sinus opacification. And so we don't really know what the true incidence is of patient has no overt dental pathology on a sinus CT scan. What's the likelihood of that patient actually having dental pathology? I think it's an important study to do in the future. But I think the take-home point is just that not all patients with odontogenic sinusitis will have overt dental pathology on a sinus CT. And so you need to keep that in mind if you're taking that patient to surgery. Get that sinus culture, see if it shows oral organisms. If so, get that dental workup. Alternatively, if you have a close relationship with dental specialists, you could get that patient's teeth assessed with appropriate endodontic testing, which, should we go into endodontic testing?
Sure. So we actually have an idea of what the conversation should be if we have to call referring providers.
Yeah. So I think one helpful thing is when you see a patient that came back from their dental evaluation and says, the dentist said it was fine, there's no dental disease. If you know about endodontic testing, you can at least ask, did they do the following? So putting a cold stimulus on the tooth is called the cold pulp test. It's one of the simplest but most predictive tests for assessing whether a tooth is necrotic, as in the pulp chamber is infected and dead. A lack of response to cold stimulus is suggestive of that. I won't go into all the different types of pulp testing. There's cold pulp, hot pulp, electric pulp, but you want to hear that the patient got some form of pulp or endodontic testing, not just they got a dental x-ray and, they tapped on my tooth. Okay. The tapping on the tooth is not as predictive. And then I guess I didn't mention this earlier. I just said dental x-ray. I want to clarify that point. So there are what they call routine bite wing dental x-rays like we all get when we get a dental cleaning. That is not showing the apex of the tooth. It is extremely common for patients to go to their general dentist in this situation and get routine bite wing dental x-rays. That is not going to help the workup. So that's why I don't know if I've stressed it enough yet, but if you can work with dental specialists, endodontists, periodontists, or oral surgeons, they're more likely to do appropriate endodontic testing and get appropriate higher resolution cone beam CT scan imaging.
So usually the patient has seen their dentist. Do you ever call the dentist? When are you in your own mind like, maybe I need to refer to an oral surgeon or an endodontist?
Right.
Does that come up?
Oh yes. So I spent years identifying, I must have called 100 different dental providers. And I had to learn what an endodontist does versus a periodontist versus an oral surgeon versus a general dentist. I therefore have a bias perhaps, but I just see the difference in the thoroughness of the examination, the imaging, the treatment, success, and all these things. And that's why I prefer interacting with dental specialists on this topic. There are no publications on this topic in the general dentistry literature. So endodontists are more in tune with it. Oral surgeons have published on it. So I just feel like there's a better awareness of the condition. For me, I don't send patients to general dentists anymore. I have a few people that I can refer them to, or I ask them if they have their own endodontist, periodontist, or oral surgeon. If they do, that's totally fine by me. I will get their contact information. And that does become a very tricky thing if you don't have a network set up of some sort, contacting these dental offices are very challenging. So it's honestly, in my mind, one of the most important parts of making progress on this condition long term. We need to find a better way for rhinologists and general ENTs who are managing this condition to connect with dental specialists. But I definitely refer directly to them.
Yeah, that's interesting because in rhinology, we have such good contacts and partnership with opto. We have great partnership with neurosurgeons. We don't think about, just given how common now that we're more aware of ODS, the importance of having our endodontic OMFS colleagues. That's interesting.
The other tricky thing is that dentistry as a specialty kind of exists outside of healthcare. It's a different insurance for patients. Not all patients have dental insurance. So how does that come into play? Like, correct me if I'm wrong, how does medical insurance cover an endodontist or?
Because the diagnosis is odontogenic sinusitis. Does that help at all?
Does that ever
Did
come
you
up?
guys secretly read my other paper?
No.
I swear that I'm not trying to be weird about these publications.
No, but we're going to, apparently there's like lists of these papers. And so we're going to need all of the references that we're going to put on their show notes so our listeners, so we can actually all read them. So I can actually
I'm not making this stuff up, I swear. So I agree. I was finding some very interesting trends with regard to patients' decisions on dental versus sinus surgical treatment based on their financial means, either their insurance or dental insurance versus medical insurance, looking at their deductibles versus their dental insurance coverage. They were actually changing their management plan. So we looked at this, and I worked with an economics guru here at Henry Ford that I could not have done this analysis without him, and basically looked at, based on diagnostic and therapeutic codes for all types of ODS, as in root canals, extractions, dental implants, bone grafts, and then sinus surgery codes. And I won't go through it all, but we found that just raw cost-wise, a root canal and dental extraction cost about the same, actually, on the whole, when you consider rates of failure and all these different things. It was about half the cost of, say, upfront sinus surgery followed by appropriate dental treatment, which makes sense in the sense that it should be more expensive. But the whole problem here is how variable people's insurance is. So some dental insurances cover more of these specialty dental procedures. Some patients' deductibles for sinus surgery are high versus low. And so I guess my point here is just that is something that I think we should try to take into account for patients when we consider types of dental treatment and the order sometimes in which you do dental treatment versus sinus surgery.
As you're referring patients for that evaluation, if you have a patient that doesn't have dental insurance, who's evaluating the teeth?
Yeah. So what I do is I try to ask them what their preference would be, but I don't think most ENTs would want to go through this. But so if they don't have, I do ask if they have dental insurance. And if they say no, I explain to them that if they have an intact tooth, the cheapest treatment is going to be an extraction. Okay. If that's all they want to do. But the tricky thing is, and this is why it's important to have dental collaborations to explain all these downstream effects. If you pull a first or second maxillary molar, there's a good chance you're going to have issues with occlusion, biting, chewing, sometimes aesthetic concerns. And so a lot of those patients are going to need some form of reconstruction. And that could come in the form of a partial denture, a bridge, or a dental implant. And those are obviously very expensive. As opposed to, say, a root canal up front, you might preserve that tooth and it'll be just the cost of that root canal. So I actually do have that discussion with people, and it guides me to refer them to either an endodontist or an oral surgeon / periodontist. But it's sort of a nuanced discussion, and it's based somewhat on my knowledge now of the costs of all these procedures.
As we're moving on to kind of talking about the management, after you've kind of have that suspicion for ODS and you're talking to the patient about, okay, this is probably an infection that's coming from a tooth. What do you do next as far as like medical management and the evaluation from oral surgery, endodontist, periodontist? What's the order of operations?
Yeah, I think one thing that's going to be helpful over time is if we start grouping these patients into treatable versus non-treatable dental pathology, which sounds obvious, but there's actually a number of different conditions from the teeth that won't be treatable if they already had a prior treatment, for instance. And so once you identify them, then you kind of have a better idea of where am I sending this patient. So We'll start with the more straightforward thing. If they have a treatable dental source, so they have an untreated tooth that has a periapical abscess, or they have an oroantral fistula that's draining pus through the tooth socket that you see. Well, these things won't resolve until you address the dental source. So, we talk about maybe we saw the sinusitis endoscopically. You can treat that patient with antibiotics to temporize their symptoms, but if you didn't recognize that there was a dental source, that patient's going to recur. And that gets back to the point of you got to recognize that there's a dental source, or you're going to treat this like recurrent infectious sinusitis. So point there is just that for treatable dental pathology, antibiotics are not curative. So you need to get that patient to a dental provider. Now, if we move on to non-treatable situations, it gets a little more interesting. So what if you have a patient who has odontogenic sinusitis, had an extraction, so there's no infectious dental source anymore. They still have purulent sinusitis. What do you do there? Well, I think it makes sense to at least try an antibiotic if there's no treatable dental source. What's interesting is how infrequently they resolve. And we've actually got a prospective study going, it's multi-center right now, looking at the rate of success of antibiotic use after dental extraction. It's very low, and we don't know all the reasons why. But so in any case, as far as antibiotic therapy, I don't think we should think of this as curative. It's usually temporizing symptoms, but probably worth a trial in situations where there is no treatable dental pathology.
What antibiotics do you like?
It's awesome when they don't have penicillin allergies. So then it's simple. It's Augmentin all the way. I work with infectious disease as well as dental providers on this point, and we all agree that's a great go-to. If they have a penicillin allergy, you'd like to think clindamycin. Great, covers anaerobes, gram-positives. Unfortunately, at least at Henry Ford, we have a pretty high rate of clindamycin resistance. So if you don't have that, then I would go to Clinda. If you do have a concern about clindamycin resistance, a lot of places will give Flagyl, but then you usually have to combine that with something that covers gram-positives. So that's why I'm saying it's nice when they don't have a penicillin allergy, because I've talked to ID and they're kind of between azithromycin, for instance, plus Flagyl, or maybe a tetracycline sometimes, but I won't give any more information on that point.
And is this like a 10 to 14 day type of course, or do you need to do like a 21 day that we think of with CRS, and because most of these are pretty indolent?
I know. We don't have that answer either, but I know for our study, we're doing 14 days. There are some studies showing that 3 weeks is usually of sort of futile in CRS. So we just shortened it to 2, but relatively arbitrary there.
Do you ever think about steroids? You mentioned sometimes you see polyps. Do you ever think about adding some steroids just to help with all that big inflammatory response?
So when I do see those patients, sometimes, but I got to say, most of the time I don't. I think my problem is I've seen such infrequent resolution with medical therapy for this condition that I personally haven't seen a robust response with steroids. But you're right. If you had severe edema, you definitely make that argument.
Do you ever get fungus on culture or anything weird like that?
Yeah, fungus definitely needs to be explored more with regard to dental pathology, because there are a few studies showing some relationship between fungal balls and prior dental implants, for instance. I personally don't send fungal cultures in purulent sinusitis when I don't see any fungal debris, unless I was concerned about invasive fungal or something, immunocompromised patients for sure. But there's not much out there on fungal cultures for this. There also is not much on like next generation bacterial DNA sequencing, which would be interesting. We might look into that. But you're right. We probably should figure out what the fungal contribution is. It seems anecdotally to be low, but can't say it with certainty.
Yeah. Do you have them do sinus rinses? Because, there's sinusitis there, and that's what we do, is to tell patients to rinse.
Yeah, I usually do just symptomatic relief. Pretty much everybody with sinus issues, I'll offer sinus irrigations. But again, for this problem, there's usually such edema and pus in that middle meatus. I don't think you're doing anything more than just flushing out temporarily the pus that's draining into the nose, but it's not penetrating the sinus.
Yeah. When you know that this is an odontogenic sinusitis, you're talking to your patients and you're like, we're going to do antibiotics and we're going to have you do some rinses and we're going to have you see the endodontist. Do you go ahead and talk about surgery? Because, as you alluded to, like, especially these patients that have non-treatable sinusitis, or they don't have a diseased tooth anymore. It sounds like the likelihood of having surgery is very high. And so are you kind of already talking about that because you are anticipating that this isn't going to get better with antibiotics alone?
Yeah, I have I also sort of bias because of what I've been studying, but I have extensive convos with them about whether they have treatable or non-treatable dental pathology. And then we talk about the benefits and risks of upfront sinus surgery versus dental treatment. And I think the tough thing is in the literature, if you look at the largest studies, the average success rate for resolving odontogenic sinusitis with a dental extraction, on average, there's some higher, some lower, but it's about 60%. And one negative predictor in 4 studies that I'm aware of that have looked at that has been extramaxillary disease extension. So if you've got ethmoid frontal or sphenoid disease, that upfront dental treatment is probably going to be even less successful. So I know in my practice and talking with colleagues, it's probably less than 50% success. But so I just talk to patients about that potentially high likelihood that they're going to need a subsequent sinus surgery. But the other variable is their symptom burden. So I think this is really important to gauge because it's not black and white, like you said, whether you do dental treatment or you do sinus surgery. I think one huge decision modifier is, are they miserable? I keep alluding to studies, but we showed in a nice prospective study that upfront sinus surgery, fairly intuitively, led to faster symptom, quality of life, and endoscopic resolution of pus, edema, all the findings, compared to upfront dental treatment. So if you get that tooth treated, yes, for me, flip a coin, it might get better. It's going to take longer to get better, usually. Every once in a while, you'll get somebody that gets their tooth pulled and they feel amazing the next day or within a week. But in our study, it was 1 to 2 months before they had symptomatic relief. And so if they're miserable, you have to then, if you send them off for dental treatment, unless you have a system set up, they're going to have to find a dentist. They're going to have to get teed up for a procedure, bring them back to the office, get that tooth treated, and then hopefully you've arranged somehow to see that patient back. But my point here is that the time can get drawn out quite a bit with upfront dental treatment, and it might not even work. So for my really miserable patients, I explain to them that we can get you in on average within about a month to get this quick, pretty low risk surgery, get you feeling better faster. And in the interim, I usually get them seen by their dental provider. Sometimes they'll get the tooth treated up front. And then it comes into not only how miserable they are, but their insurance status. So if they can't afford sinus surgery because they're deductible, they're going to not do that. And maybe they'll elect some dental procedure. And again, the permutations of different reasons to choose upfront dental surgery versus sinus surgery is real for patients. Like there's different reasons that they decide to do one or the other. And I'll try to bring this all home now with just the simple ask patients how miserable they are. If they're really miserable, we can at least offer upfront sinus surgery, but they can always get their teeth treated first. But we need to see those patients back because if that sinusitis doesn't resolve, they're going to have a long-term risk of things like extra sinus complications.
So that's actually my next question. How long do you give the patient after they've had a dental treatment to say, oh, the dental treatment worked? How long you said about 1 to 2 months, and then when do you see them back, and how long do you give them before you start thinking surgery?
So this is also arbitrary, but it's based on international consensus mixed with national consensus. And so, in our study, it was 1 to 2 months before the successfully treated dental patients got better. But then some other oral surgeons and endodontists felt that was sometimes too short a duration. So somewhere between 1 to 3 months we agreed on. And therefore, I took the middle ground and said, all right, I'll see my patients back in 2 months. But if they're miserable, within a few weeks of that dental procedure, they can totally call me and we can actually either see them back in the office sooner or, depending on the situation, maybe just book the surgery. But does that make sense? So I aim for 2 months. I think that seems pretty reasonable. And if it's not better by 2 months, they're not getting better.
Yeah. And when you're doing sinus surgery, are you just doing a maxillary enterostomy, or are you treating, every sinus that's diseased on the scan?
And also, can you just do balloons, or do you need to do, how big does enterostomy have to be?
So balloons we agreed on in our management national consensus to not be appropriate for most cases of odontogenic sinusitis. largely because there's usually significant edema in the middle meatus. Might even be tough to cannulate the maxillary sometimes, very friable edema. And then you need a wide enough opening to clear out. The whole point of surgery is to clear out all the pus. It's almost like draining an abscess. You really want to clear that out. And with a balloon dilation, I know I've heard some people say, well, you could flush the sinus after. But I don't know. I've seen the inside of a lot of maxillary sinuses with this condition, and there's so much polypoid edema in there. I don't know that you could reliably flush out all that pus. So I don't know, for me, and I know other colleagues studying this, like we want a wide maxillary enterostomy, clear out the pus. Now, the next question you asked is an intriguing one. How much sinus surgery do you then need to do? So a group, they looked at this. So Ahmad Safadi, he and his group looked at 45 patients prospectively. They had maxillary, ethmoid, and frontal disease, and they did only a maxillary enterostomy and showed 100% resolution of the disease, presuming the dental source is treated. So it's only one study so far, and we're going to look at this too, but it is intriguing that maybe you don't need to open all diseased sinuses like we do with other forms of rhinosinusitis. I would say that that's in the non or uncomplicated ODS situation where you don't have spread outside into the eye, brain, other areas. If you have complicated ODS, I think it makes sense. If you're going in, you should drain all the purulent sinusitis potential source of that infectious complication. But if you're wondering what I do, I've sort of evolved, I say, or migrated over time. I used to address all disease sinuses, but I admit I had a frontal stenosis after one of those cases, and I had to do a draft 3 for that patient to resolve that. And then I saw Dr. Safadi's paper, and it got me thinking like, well, maybe we don't have to open all sinuses. So I think we don't have the perfect answer yet, but I do think it's reasonable based on what's been published and then just what I've seen, that if you're not comfortable opening a frontal sinus, you shouldn't go up into an ODS frontal sinus especially. It's very inflamed, probably higher risk for stenosis. We don't have that answer yet, but I think maxillary only is an intriguing option.
Given that we just said how inflamed these sinuses can be, do you do most of these or all of these in the OR? Do you ever do these in the office? And do you always use navigation, or does it just depend on what the patient has?
Yeah. Me personally, I've never needed to do these cases in the office. I can get them on my OR schedule pretty quickly, and they're relatively short. People doing a lot of in-office procedures have a nice system set up. I've talked to some people doing these cases in the office. So I think it all comes down to your comfort level. If you're comfortable controlling pretty significant oozing and you have a team in your office, I think that's totally fine. If you feel it's safe, that's great. Me personally, I want to make that opening really wide, deal with any arterial bleeding that might pop up. And so I do in the OR. But we usually have navigation protocoled CTs ordered whenever we order the CT. So it's almost always available. I mean, for a maxillary enterostomy, really using that navigation. But I think if you're going up along the skull base and frontal sinus regions, if you don't do a lot of those cases, probably wise to have navigation.
And after surgery, as far as post-op instructions for patients, I assume you have them rinse. Do you do any post-operative antibiotics or any other special medications or treatment?
Yeah, I'm still doing antibiotics after these cases. I think I usually do 10 days of post-op antibiotics. It comes down to like, it's a raging purulent sinusitis. Can I be confident I got every last bit out of the infection? Maybe not. And so that's what I've been doing. Not to say that that's evidence-driven, but there's nothing on post-operative antibiotic use for ODS. I mean, there's some studies showing no benefit in rhinosinusitis, but I think this is different and just needs to be studied better.
Do you ever wait for a culture from the OR before you call something in and get sensitivities? Or do you say, listen, this is going to be oral flora and Augmentin is going to be fine?
I love when I can give Augmentin. That's my favorite. So yeah, I usually start empirically. If it's somehow resistant to that, then I'll call the patient and switch the antibiotic.
And are you always culturing in the OR as well?
Oh yeah, absolutely. And I presume everyone does it this way, but sterilely obtained culture, essential. We had 100% culture growth rate in our microbial culture study. My infectious disease person was very happy about that. So just me personally, I use the 2.5 millimeter malleable curved suction attached to a Lucan's trap, collect that pus directly from the maxillary sinus. I feel like that's been a great way to do it. Just I would hesitate if people are using swabs and just swabbing the inside of the nose as they go in. So sterile acquisition is good.
So you're suctioning that after you've created your enterostomy, and you can actually put your suction down into the sinus as opposed to suctioning the stuff that's kind of coming out.
Yeah, I found that the middle meatal pus is not enough. When you get into that maxillary, there's so much pus in ODS.
Yeah.
So it's a large reservoir.
Yeah, you're kind of culturing the heart of it, like the middle.
Yes. Got it.
And as far as outcomes go, once you drain the abscess, basically, success rates are pretty high.
Very high. That's why this condition is so fun to manage. Once you identify it, which is the harder part, you should be seeing 90-95% success if you've addressed the teeth appropriately and the sinuses adequately. I think it's important, though, that people don't think it's just 100% success, because I know some people presume that. There's even some series, showing 100% success, but nothing can really be 100%, in my opinion. And I've seen, so we just put this out, and we did actually achieve 98% long-term resolution endoscopically and symptomatically, which was awesome. But there's that 2 to 5% group that, who knows, there's just so many variables with sinusitis, whether they're forming biofilms. I've had to do a medial maxillectomy on one patient that comes to mind and it actually wasn't odontogenic bacteria when I finally got in there. So they actually started growing MRSA. So we open these sinuses to the outside world. Different bacteria can get in there, set up shop. Maybe you have some surgical scarring. The bottom line is these patients usually do fantastic, but you just have to be aware. Some of these patients will either recur, or in my experience, it's been more a different sinusitis has occurred after.
Yeah. When you say recur, like having another tooth have problems, or the same area having issues again, something like that?
Yeah, that's a good point. I didn't specify that. So if you didn't get the tooth, there's two situations there. So if the tooth wasn't appropriately treated, so maybe an incomplete root canal or fractured root when they extracted the tooth or something, then yes, that would be a recurrence. I personally haven't seen this yet, but I'm waiting for it to happen. Another tooth to pop up and cause a second odontogenic sinusitis. Seems to be pretty unlikely on the whole, but that could happen as far as recurrence goes.
As we start to round things out, any final pearls that you want to leave our listeners with, John?
For one, we just need to all be aware that this is more common than we previously thought, and we have to look for it. Other dental providers, radiologists, other medical providers, they're not going to identify this for you. And that's actually been shown in a bunch of studies too. Radiologists, unfortunately, miss the odontogenic pathology in the majority of cases. So again, ENTs, we have to be looking for it. The things that should tip us off: unilateral symptoms, scope findings, CT findings, especially maxillary opacification. We should be looking down at the teeth on that CT and looking for dental pathology. I mentioned this earlier, but I think we're going to start pushing this message more. Opacification on that CT is what's critical. Mucosal thickening is very common, can be just a random anomalous finding, or it's very common adjacent to dental pathology or dental treatment. So scope that patient, make sure it's infectious sinusitis. That's what we should be considering odontogenic sinusitis.
Perfect. Well, thank you so much. I learned so much.
Yeah, thank you for taking the time. This is great.
Excellent. Thanks so much, guys.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Ivan Orgodzinsky.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.